The pancreas is a deep organ in the body, and when anything goes wrong with it, you know, it's too late as soon as you have symptoms. So when you have the classic symptoms of pancreatic cancer, such as pain or weight loss or jaundice, unfortunately, the disease has grown in a big enough stage for you to have those symptoms. The other thing is, because the pancreas isn't very deep in the body, it's very hard to actually do diagnostic tests, such as getting a biopsy for it. So this is in particular what makes it very hard to diagnose. Sure. So the reality is that once you start having signs, the likelihood is that you are more in trouble with this disease. There are a small set of patients that do develop jaundice, and this is when the tumor is able to block off one of your ducts, and that's realistically the only time where one could pick up early disease. Once you start having other symptoms, it seems like, unfortunately, the disease has spread. Sure. So the reality is surgery is unfortunately only used in about 15% of cases. There is another 35% of patients that have localized disease, and unfortunately an operation is not amenable at that time. The mainstay of treating pancreatic cancer is with systemic therapies, so in this particular case, chemotherapy, and that's what I specialize in doing. And whether you have metastatic disease or a tumor that requires an operation, you're going to need chemotherapy to help give you the best chances. Okay, so the survival rates, unfortunately, have not changed much over the last 50 years. So in the UK, I believe we still quote a 5-year survival rate of about 7% of people in 5 years. Though, the earlier stage diseases do better. So if you are having an operation, unfortunately, most people still succumb to the disease because of relapse rates. But we normally quote 2 to 3 year survival. This, though, is hopefully changing, because we know that patients who are exposed to triple chemotherapy do better. And we are also bringing in what we call multimodality therapy. So we're seeing more patients who do well with chemotherapy being amenable to radiotherapy or ablations, or in some unique circumstances, operations. But this is still, unfortunately, a select group of patients. Sure. So being a disease that has a poor prognosis, the reality is there's a lot going on in research, and my job here at the University of Oxford, I hope, is leading that in many ways. So in the diagnostic spectrum, we are now starting to see from large records when we could try and diagnose patients earlier. So we know that there's a group of patients who will present with diabetes, and so therefore that's an opportunity to try and pick up 1 in 4 patients. We are also looking at non-invasive testing routes, such as circulating tumor DNA, and that's proving to be very exciting as well. From the treatment spectrum, what we really need is new drugs for pancreatic cancer. And in my unit here, we've got several trials with exciting new compounds. What's topical at the moment is immunotherapy, and we know that the classical immunotherapy doesn't work in pancreatic cancer unless you're in the 0.5% of patients that have Lynch syndrome, but we know that there's other different immunotherapy targets that we could target in pancreatic cancer, and we're going quite aggressively after them. So watch this space.